So we've got no questions coming through at the moment on the app. I just want to open the floor up to questions. Please do come to the mic. There's one there and there's one there. Don't be shy. We're all friends here. Come up to the mic and do ask any first question or anything you've heard in this first session so far.
Can I jump in with a question?
Yes.
Okay, this is a question for Simon. Thank you very much for making that the guidelines into those bite-sized chunks, because I know how much is in there, and you did a good job with your slides. I'm really curious, though, about to hear from others here about stent management, because we hear so many difficult stories from people who have been stented and then actually have no idea that once you have a stent, that's not something that's going to be permanent. I mean, permanent in that it's not going to block, you're not going to get infected, because they probably will block and get infected. And we don't see that people have that are given or go away with information on how to care for themselves. So I was really interested in that, having the emergency antibiotics. Not many people get that. How can we address that?
I think it's always difficult, isn't it, because a patient moves along different parts of the journey. And I think sometimes, perhaps more as gastroenterologists, stent care is something I'm very passionate about, because it's something I do day in, day out. Yeah. So one thing we've started to institute at our centre is making sure patients have regular blood tests, which I know they're going to have through oncology, but perhaps looked at by the HBB nurses. They're still under gastroenterological care for their stent management. And obviously, if we see signs of stent dysfunction, we act appropriately and get further imaging. A bit like PSC and other benign disorders where you can get recurrent infections, there's a lot of work from PSC support about having cholangitis cards, the symptoms to look out for, rescue antibiotics, and more importantly, a number to get in touch with to try and get emergency admission if it's not working and improving. And I think that's the role where perhaps sometimes when these patients get moved on to the next part of their pathway, we could still work better to not, if you like, keep both of them under different watchful eyes. Because I think, and obviously bringing those patients back to MDTs is really important, looking up the up-to-date scan, deciding what's the best way to manage that stent dysfunction. So I don't think that answers your question.
Well, it does, and I'm just thinking, my brain is whizzing along, that maybe we need something like a national stent care helpline or something like that, so people, because we've had people come to us and they say, talking about, say, for example, their sister who is stented. She's spiking a really high temperature. This is Monday. Does she have a stent? Yes, she does. But she's got an appointment with her consultant on Thursday. So is it all right to leave it till then? Well, if you do, she's probably not going to still be with us, because she's probably going to get biliary sepsis.
Yeah, I mean, I think these patients need rapid ability to get back into hospital and rapid access to it.
And people, that number, a number, a clinical nurse specialist number, not everybody has a clinical nurse specialist, something we're passionate about. Yes.
Yes, thank you. We do have a question from the virtual platform for you, Simon, as well. So they're asking if the guidelines also include some guidance for the turnaround for pathology and molecular workup.
Yeah, they don't actually put a time frame in there, because we know at the moment for the individual genomic hubs, it's obviously heterogeneous. So we didn't actually recommend a guideline. Whether that's something we will change, but it's difficult to, if you like, suggest that in the absence of evidence. But I think the most important thing was it's done and thought about at the start of the patient's pathway and not left. So then when obviously they break through on first-line chemo, there's a delay potentially of 6 to 8 weeks while an answer is obtained. So I think it's really thinking about it up front, documenting it, and also writing down if there's not enough pathological material to do it in, and how you're going to address that.
And I think that each institution has its different, time frame, so probably that is something that has to be considered internally. So we have a question from here.
I'm a patient based in Scotland. There's quite a lot about NHS England and stuff. Can you reassure all of those of us based in the devolved nations that these recommendations, which look great, will be sort of appreciated and adopted elsewhere?
Well, I can probably tell you that yes, we follow these guidelines, as well as oncology. I'm a medical oncologist, so we tend to participate to the delineation of guidelines international, and we do follow them. Obviously, as in England, in Scotland, and in Wales and other countries around Europe, there is the difficulty of reaching out peripheral hospitals. So we have plans to really disseminate these guidelines. And I think this is really what I've put to ask probably the three of you here. So writing guidelines is always good, but what's the plan? What's the next step to really make sure that these guidelines reach out to the more peripheral hospitals and people who are not here?
I mean, I think there are things we could do. I mean, some of the guidelines on the BSG have a video attached to them. So for people who just want a short bite size, here's it in 5 minutes, 10 minutes, those are things we could do. I think perhaps we should record them for the AMMF, and be able to send them round. We have lists. We're going to do potentially a large-scale audit. We should be sending around videos to audit leads, of these guidelines to make sure they're disseminated. So I think there's lots of things you can practically do to disseminate the information.
We're also presenting the.
Yes.
We're also going to be presenting this at the annual BSG meeting. The guidelines, though, it is what it says on the tin. They are there to guide. They're not medical legal law. They are thought to be best practice. So it's up to the community, the medical scientific community, to get the word out and ensure best practice is done. But we're not a police force. We can't ensure that every hospital in every part of the corner of the country adheres to them.
Could I just come in on one thing there? I would also suggest, and it's very difficult because not every patient are like those that are with us today, the sort of educated patient, but download the guidelines, get hold of a copy of the guidelines. They're on AMMF's website. If you don't think your treatment is following the guidelines as it should be, show your oncologist the guidelines.
Have a question from Professor Davidson.
Question for Simon. So thanks very much for all your fantastic work on the guidelines. I think they're really excellent. One of the points of doing guidelines is to highlight what we don't know, and obviously we don't know quite a lot of things. Particularly in your area of expertise, there's the question of whether or not we should have a trial on endoscopic ultrasound-guided drainage. Two questions for you. Do you think it's required, and does it have to be cholangiocarcinoma specific? Because there is clearly the possibility that we'll get an answer that doesn't identify whether or not it's particularly beneficial for distal cholangios rather than other periampullary cancers.
Yeah, no, I mean, I agree with you. I mean, I think for the, the more simpler one, which obviously for the more distal malignant tract obstruction, if we were ever going to do a trial, it should be all comers, because the technique is the same when you've got duct dilatation above a pathological lesion at the bottom. I mean, I think the evidence is relatively convincing about, but I think the major thing for me is when you're starting these things is that audit data. I think what's been nice in the endoscopic community for other things that have come in, like, for hot axious drainage of collections in the pancreas, through Newcastle, we've collected 700-800 cases and published those. And I think those are much more informative when you look at everyone's practice up and down the UK, where you get a better readout probably of the spread of variance for the procedure, the complication rates. So I think perhaps, and it is being done, there is national EUS databases set up to collect this data. So I think in time we'll have good data of hundreds of cases to give people, some confidence about the complication rates. But I think it's very difficult when you're changing from one modality such as PDC to EUS-guided drainage, and how you do that in your own centre and keep an eye that you're doing as well as the published literature. I think those are hard things to do. And that's where, having access committees and new procedural committees in your own hospital is absolutely valuable. But I think it is for distal obstruction. I think it is a good technique, but I think we need a bit more information, as you're perhaps alluding to.
And just one quick comment. We don't have a prospective trial on hot Whipples, which is what you alluded to, and there is no high-quality level 1 evidence for that, as you mentioned. And again, clearly an important need as to whether or not we should be draining or just resecting these patients.
One question from the virtual platform before we move to Johan. Is there any mention in the guidelines about hepatic arterial infusion for perihilar cholangiocarcinoma?
What, sorry?
Is there any mentioning about hepatic arterial infusion chemotherapy for cholangio?
They're very alluded to very loosely, but there is no formal recommendation about it.
Yeah, so there's no formal recommendation because the evidence base was not really strong enough. Unless you,
Yeah, no, I mean, I completely agree.
as
I
an
think
oncologist, think that.
I think that there is a growing preliminary evidence that is building up for intrahepatic cholangiocarcinoma, and so maybe we just need to wait the data and put them within a research prospect before we put in guidelines. Johan?
Thank you, and thanks for the presentations, and compliments again to Helen and the whole team at AMMF for the work they've been doing over the past year. This is more of a comment rather than a question. Increasingly for clinical trials now, we're producing plain language summaries, which are then being published. I wonder if there are thoughts about a plain language summary for the BSG guidelines, which would then be much more user-friendly, I guess, for patient community.
I think it's a really good idea.
Yeah.
I mean, you know, EASL have done something similar for a fatty liver disease where they produced patient guidance, and I think they were excellent. They talk in a lovely, simple language that everyone can understand. I don't think the BSG yet has a route for doing that, but it doesn't mean we shouldn't approach them and propose it as an idea, because it's a really good idea.
So we need to conclude this session. Just before doing that, I want to bring a question from the online platform, and it's for Ellen. I think you are the best person to answer. Do patients take part when discussing the guidelines?
We didn't have patients as such, but myself and Martine Wormsley, who represents the PSC community, she's chair of or CEO of PSC Support UK, were given really carte blanche to have our say and comment on every area of the guidelines. And in fact, the part that Simon showed, which was how important a nutritionist is, how important clinical nurse specialist is, etc., that was all from us and had not been put into guidelines before. So yes, really, patients did, and we represent the patient. So yes, we did.
Thank you.